I'd like everyone that's within the sound of my voice to take a deep breath in and then breathe out. Take another deep breath in and breathe out. And breathe out. More. Take another deep breath in and breathe out. And I want you to reflect on what it is that I'm getting ready to share with you. And you can close your eyes. You can just sit in a comfortable position, but open your mind and just think about what it is that I'm getting ready to share with you regarding this topic. And firstly, in terms of substance use disorder, in 2020, the overdose rates per 100,000 increased 44% in African-American communities. Also, in 2020, overdose rates of Black males that were 65 and older were 7 times that of whites. This is according to the CDC. African Americans between the age of 15 and 24 had the largest increase, and that increase was 86% of overdose deaths compared to other groups during just 2019 and 2020. And that is according to the Center for Disease Control. Even more, only 1 in 10 Hispanic people receive treatment and for substance use disorder, and that was even lower for African American persons. Another important point, even though in some communities there's a higher availability of treatment service, this does not mean that this translates to increased access service for African Americans. Increased deaths in 2020 was catapulted by fentanyl, which is 100 times more potent than morphine, and literally is driving the overdose epidemic. And in terms of just some other statistics, 44% of Black men are overweight, 37% are obese. There's a higher incidence of diabetes as well as prostate cancer among Black men. And also, equally important, there's an increased rate of suicide. And probably the most salient thing that I want you to take away from this presentation in terms of HIV/AIDS, the CDC proposes that 1 in 2 Black same-gender loving men will acquire HIV within their lifetime if there's not some significant evidence-based interventions put into place. So I'd like you to open your eyes now and relax and reflect on those rather startling statistics. And so again, that really is why it is so imperative that we're having this conversation, that we are having this discussion, not only about the problem, but also about solutions. And also, I want you all to co-create with me solutions, because for many of these topics, we've been having these conversations for many, many years, especially around HIV and AIDS. During the epidemic back in the early 80s, the face of HIV/AIDS were white gay men. Now, Black gay men are at the epicenter of the HIV/AIDS epidemic. We have our work cut out for us. So in terms of our objectives, we want to examine health disparities affecting African-American men's health, particularly focusing on HIV and AIDS. We also want to discuss issues related to substance use disorder and social justice. We'll explore issues related to same-gender loving men and health. We'll also examine and increase our awareness related to our own personal biases. Also, we'll discuss the issue of intersectionality, and we'll examine evidence-based solutions in working with and affirming African-American men. And lastly, again, we will co-create person-centered solutions in working with African-American men. So let's contextualize first what we mean by health. And we all have our ideas on what health is, but according to the Medical Network, they have what I feel is a very comprehensive definition of health. And they state that, firstly, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. And so as we move forward, help us to remember this as a more holistic definition in terms of what we mean by health. Also, it should be approached as a holistic rather than just a series of separate entities or separate factors. Also, cultural issues can also affect health, and we'll examine that a little bit deeper. And lastly, well-being and balance are the keys to good health. And I think that definition is comprehensive, it's inclusive, and this is a definition that I think as we move forward that we can totally embrace. So let's look at what we mean by health equity. And we want to compare equality with health equity. But let's give us a working definition of health equity. And this is what the CDC says health equity is. And this is a fairly new definition. And I think it's more comprehensive than some of their previous definitions. But they state that health equity is the state in which everyone has a fair and just opportunity to obtain their highest level of health. Also, achieving this requires focused and ongoing societal efforts to address historical and contemporary injustice. And so that's true. That also means that the voices of Black men, the voices in the Black community also have to be a part of solutions, have to be a part of what we call health equity. In terms of the defining health equity, also it includes overcoming economic, social, and other obstacles to health and health care, as well as eliminate preventable health disparities. So this is, again, a fairly new definition from the CDC that was actually put out in 2022. So let's look at the slide on the right-hand side. So you've got equity and you've got equality. So if you look at, for example, equality, because many of us say, well, we want to disperse resources. We want to give our clients equal kinds of resources across the board. But look at what happens when we just say and utilize the concept of equality. You'll see that in order to get, let's say the apples here are resources. In order to get them, you see that everyone in this first box is not able to get the resources that they need, because each box is at the same level. Okay, everybody with me now? Everybody can hear me?
Yes.
Okay, but look at this second box on your right-hand side when we talk about equity, because this is what we are trying to achieve. When we make sure that the boxes, see that first box, and you see the individual is able to reach the tree and get his resources. So is the second one, and so is the third one, only because the boxes have been changed in terms of accommodating each individual so that they're able to achieve. So in other words, when we talk about equity, we're talking about outcomes, and we're talking about making sure that our clients are getting what they need in order for them to be successful in their endeavors. So let's look at men's health and race. So can everybody see that screen?
Yes, sir.
Okay. So changing trajectory just a little bit. So when we talk about Black men's health disparities, we cannot separate this from our history. We cannot separate Black men's consciousness and why it is there may be barriers to, number one, accessing healthcare, but also the reluctance on the part of our community to trust the healthcare system. And so when we look at some of these stats, Black men die more than 7 years earlier than do women of all races. This is in the US. Also, Black men die younger than all other age groups except Native Americans. These are startling statistics. And lastly, HIV/AIDS is 7 times more prevalent among Black men than white men. And that goes back to that statistic that I gave you: 1 in 2 Black same-gender loving men will get HIV within their lifetime. That has grave implications. And so on the next slide, let's take a look at what I consider one of the most powerful videos and powerful movies, if you get a chance to look at it. It's called Miss Evers' Boys. And as you're watching this video, I want you to make sure that you are thinking of points that you can put in the chat that come to mind as you're watching this video, because what this video does, it really explores and examines the Tuskegee experiment. And we know that that was one of the worst atrocities against Black men at the hands of the government, at the hands of an institution that is supposed to protect its members, but nevertheless, they cause some pretty startling statistics. So for example, the Tuskegee study really was a study of untreated syphilis in the Negro male. So they really focused on the male population. And this was between 1932 and 1972. So it wasn't really too far in the past. And again, this was by the U.S. Public Health Services and the Center for Disease Control. And the study employed 400 African-American men with syphilis in Macon County, Alabama. And even though there was a cure, there was penicillin available, many of these men were not giving life-saving treatment because of this research study. And some of the aftermath that probably many of you don't know is that because of this, many men died. 128 participants died of syphilis-related complications. This was preventable. There was a cure for it. This did not have to happen. Also, 40 wives were also infected. And 19 children, here it is, 19 children were born with congenital syphilis. And lastly, families suffered from the stigma associated with syphilis. Even though there was a cure that could have been given to these men, it was not. So let's just listen to this video, and hopefully everyone can hear it. And what I want to know in the chat is your thoughts. Can everybody hear?
Yes, sir. Can you turn it up just a little bit, Dr. Bryant?
Somebody said, you see that hill there? You just got to climb that. And when you get up that hill, you see there's another hill behind.
Oh, that's as high as I'm able to turn it up.
See, that's the top right up there. So you climb again. And sure enough, you get there and there's another hill. And by then, you have just come so far, you figure you might as well go. Is that better,
Dr. Tyus?
Yes, that's good. Thank you.
Okay.
Come of your own free will.
I thought I was doing good.
You are. You are doing good. Don't ever let go of that. You're doing good for those men, and you are doing good for Negro people.
Why can't I look him in the face when I'm crying?
We all want to cry, but we have to be strong, and you are a strong woman. And I know that you'll do what you are called to do.
Excuse me, nurse, we're here to get this man a penicillin shot.
Name?
Willie Johnson.
Can't help you.
Why not?
Name's on the list.
What list is that, man?
Tuskegee study. No penicillin allowed.
How come I can't get a shot like Caleb got a shot? Never mind, Willie. Come on, we just go somewhere else.
Won't help. They sent the list to everybody.
Don't worry about it. Go down here.
I ain't never done nothing to nobody, but you got a place.
Yeah, I'm gonna carry you over there now.
Give me the penicillin in here. Caleb gonna take me to a place where I can get it. They say I'm on some kind of list.
Where's that shot could have killed you?
I'm still standing.
You're just lucky. Penicillin could be dangerous for him.
Why me and not him?
You're different.
Why?
I don't know. Nobody knows, but we can't take that chance. Listen to me, Willie.
Yeah.
It could have exploded your heart.
Caleb, you ain't said nothing about my heart.
He don't know. I know.
Go ahead on with her, Willie. Caleb, you said you were going to take me to get to the line about what I said.
Willie, it's for your own good.
You're going to see to it you don't get it nowhere. I know the doctors know best. Boy, they got a good one when they found you first. I got a train to catch in there.
Don't get yourself shot.
Lucky they let me near go. Hey, Willie. Yeah. Pass them down, yeah? Good man, Miss Ellen.
Yeah.
Miss Ellen. Ben is feeling poorly. He got trouble with his eyes and his legs too. Now that only leaves me in hardness for the chili. Hey, Miss Ellen. Think I'm still gonna make it to the Cotton Club?
I'm gonna give me a new hat and sit right up on the front row.
Tell me straight.
I'm gonna see you through this clinic. You hear me? I ain't left you yet. I'm not leaving you now. We gonna see this through together.
You know, I've been thinking. You know about the Cotton Club?
No.
They don't allow no colors in the audience, only on the stage.
Give me a chance. Sit up there on the stage. I had heard that Caleb had been sent overseas, but a long time went by with no word from him. So I had started to think that he had gotten himself killed. Meanwhile, I did my best, but the man got steadily worse.
And
Okay. So I'm going to give you some time to reflect on that. And Dr. Tyus or Pam can give us just some responses from the chat. Anything in the chat yet?
Yes, it says, this demonstrates the long history of medical disparities for AA men in this country. A clear racial disparity.
Absolutely, absolutely.
The way the medical system developed its medicine and practices on preying on Blacks. It's the reason why even today, most men rather stick it out and not see a doctor. COVID was another example.
That's absolutely powerful. Absolutely. And so when we look at this issue of trust, we can see where much of it emanates. And we're talking about 1972. That wasn't that long ago. It wasn't like it was in the 20s and 30s. This was fairly recent. And to just know how it impacted our community, you can very well see that building trust between African-American men particularly and the health system is going to take a concerted effort. I believe that we've made strides, but I think that we need to even bridge that gap. And I still feel like there's a gap in terms of trusting the medical establishment. And so let's kind of change trajectories a little bit, because the other overarching issue in our community, which certainly includes Black men as well, is substance use disorder. And so when we look at overdose deaths now, particularly as a result of the opioid epidemic, we see that overarchingly that it impacts the African-American community. And I said a quote or stat of 44% of Black men, or it's been an increase of 44% overdose deaths in the Black community. That is very, very pervasive. And that certainly has grave implications for our community. But when we talk about the opioid epidemic, because it mostly impacted white rural communities, African-American needs really have been put on the back burner. And the overarching thing here is our response to this epidemic. And so you had a president who said, because of the opioid epidemic, this is a public health emergency. So contrast that to, for example, the crack epidemic. Even though as African Americans, we didn't use, whites actually used crack more than we did, but it was our face that was on the 5 o'clock news associated with crack. It was us who basically filled the jails because of the use of substances such as crack, and the disparity between powder cocaine and crack cocaine. And so you can see that race sort of intersects policy, but particularly public health policy. In contrast, when we look at the opioid epidemic, there was more of an empathetic response, such that more programs began to be developed, more hospitalizations were made available. And so the response was different when we're talking about a issue that impacts whites as opposed to issues that impact African Americans. And so, and moving to the next slide, let's look at some trends in terms of substance use disorder. So again, and I want to keep reiterating this, and that is in 2020, overdose rates per 100,000 increased 44% among Blacks. Also among Blacks between the age of 31 to 47, overdose deaths in 2025, and this is a projection, are expected to increase by 440 or 11% relative to 2020. So this projection is saying this is going to get worse in our community by 2025. If there's not a very serious intervention that is evidence-based and that actually works in our community. And in terms of the Center for Disease Control, they estimate that from 2015 to 2020, the drug overdose death rate for non-Hispanic Black men more than tripled. And so you've got substance use disorder, and you've also got HIV and AIDS as adversely impacting African-American men and African-American community overall. And just to sort of put this in perspective in terms of overdose deaths by race and ethnicity, and this is an infographic that I think really brings home the fact that African Americans are at the epicenter when we're talking about overdose deaths by race and ethnicities. So let's look at drug policy and systemic racism. And so what we're seeing here is, for example, the demedicalization of and criminalization of substance use disorder. So in other words, we know that substance use disorder is biological as opposed to some kind of moral deficiency. But oftentimes, even medical providers don't always see it that way. Oftentimes, some providers, and this is from nurses to physicians, feel like individuals that do have a substance use disorder, that it is their own fault and that they can stop at any time. But it is very clear, and the evidence supports that substance use disorder is a biological disease, very much like diabetes, like asthma, some other disease, and should be treated and afforded the same kind of empathy that individuals that suffer from a substance use disorder. Also, inequitable expansion of treatment. And so when we're talking about HIV and we're talking about medication for addiction treatment, there is an inequitable dispersion, for example, of buprenorphine and naltrexone as compared to who gets methadone. And oftentimes methadone is more pushed towards African-American community, whereas buprenorphine is pushed more towards whites. And so the literature does support that there's an unequal dispersion and distribution between African Americans and whites in terms of opioid treatment. And so again, the other thing is, and this really has become pervasive and epidemic in our community, and that is the overcriminalization and desperate policing. And we can see even since George Floyd, we're still seeing atrocities committed on African-American community and African-American men overall at the hands of the police. And so this next video, I'd also like you to listen to it and reflect on the issues around how the criminal justice system treats African Americans and the implications, as well as some of the negative outcome, not just for the individual, but also the individual's family, the individual's children. And I think this video really brings home a very powerful message on how that is operationalized.
Jim Crow was a system of laws, policies, and customs that operated to discriminate against African Americans in virtually every aspect of social, political, and economic life. Well, ask yourself if some of the rules and laws governing felons today kind of remind you of a bygone era. Denial of the right to vote, right? 47 states, the District of Columbia, deny prisoners the right to vote. But that's just the tip of the iceberg, because in the United States, pretty much the only country in the world that denies people the right to vote once they've been released from prison in many states. In fact, about 1 out of 4 African-American men have been permanently disenfranchised in a few states as a result of felon disenfranchisement laws. And nationwide, the figure is about 1 in 7. Employment discrimination. Employment discrimination, perfectly legal once you're branded a felon, right? Job applications ranging from Burger King clerk to accountant, got the box. Yeah, got to check that box if you've ever been convicted of a felony. Thousands of professional licenses are off limits to people who are labeled felons. In some states, you can't even get a license to be a barber if you've been convicted of a felony, right? Housing discrimination, perfectly legal. You know, back in the Jim Crow era was the era of racially restrictive covenants, right? Well, today, you can be discriminated against on the basis of your criminal history. In fact, public housing is off limits to you for a minimum of 5 years. Minimum of 5 years if you've been convicted of a felony. So here you are, newly released from prison, right? No money, no job. Public housing is off limits to you. Private landlords are free to discriminate against you. And, you know, your mother, aunt, sister, girlfriend who lives in public housing, well, she risks eviction by housing you, allowing you to stay in the apartment, right? So what are these folks to do? No job, can't find a place to stay, right? What are they expected to do? Well, they're actually expected to pay thousands of dollars in fees and fines. Following the collapse of slavery, you know, Black men were routinely arrested for, you know, extremely minor crimes like loitering or vagrancy, right? They were arrested and sent to work on plantations through a program known as kind of convict leasing, right? The idea was that they had to earn their freedom, but the catch was they could never earn enough to pay back the costs of their shelter and their food and their clothing. And so they remained in perpetual servitude, a system that, you know, some have called worse than slavery, right? Well, today we have a similar system. Even if a former prisoner manages to get a job, you know, you're one of the lucky few who manages to get a job, up to 100% of your wages can be garnished to pay back the cost of your imprisonment, to pay back fees, fines, and court costs, to pay back accumulated child support while you were in prison. So here you're one of the lucky few, you get a job, up to 100% of your wages can be garnished. What is the system designed to do? Right? Put you right back in prison. In fact, that is what happens about 70% of the time. Within 3 years, 70% of released prisoners are returned. And in fact, the majority of those who are returned within a few months, because the hurdles, the barriers for just making it on the outside are so extreme. Public benefits. Don't expect even to be fed if you have a drug felony. Discrimination is perfectly legal against those who've been labeled felons in public benefits. In fact, if you're a drug felon, you're ineligible for food stamps for the rest of your life, thanks to President Clinton. Even if you're a pregnant woman, someone with HIV or AIDS, basic food stamps off limits to you for the rest of your life. Exclusion from jury service. You know, of course, one of the hallmarks of the Jim Crow era were the all-white juries, you know, particularly in the South. Well, today, those labeled felons are automatically considered ineligible for jury service. In some areas of the country, you know, the all-white juries come roaring back because such a large percentage of the African-American community is deemed ineligible for jury service. Now get this, even if you haven't been branded a felon yet, if you have negative experiences with law enforcement, that disqualifies you from serving on the jury if it might lead you to be, you know, impartial in a criminal case. So good luck. You know, in many communities of color, finding someone who has not yet had a negative experience with law enforcement that just might justify your exclusion from a jury. But as bad as all the formal barriers, you know, to political, economic, and social exclusion are, as bad as all these formal barriers are, in my experience, many people labeled criminals find the stigma the hardest to bear. You know, it's not just the denial of the job, but the look that flashes across an employer's face when he sees the box has been checked. It's not just the denial of housing,
Right.
But being a grown man, having to beg your grandma for a place to sleep at night because nowhere else will take you in.
Yeah.
This really, I think, is a powerful video by Michelle Alexander. And I want to get your input. I want to get your thoughts. What do you think about this? And so as we are populating the chat, this is your chance to have your voices heard, to give your input on what you think about this powerful message that she's given us about what happens in terms of African Americans in the criminal justice system, and particularly African American men. And so she talked about housing and how the lack of being able to get housing if you have a felony is just something that's just absolutely mind-boggling. She talked about just the arrest for minor crimes such as marijuana use, the lack of the ability to get jobs, also inability to participate in the jury system, and overarchingly, the stigma that's associated with having had a felony. So do we have anything in the chat yet?
Yes, someone indicated a vicious and intentional cycle to keep you imprisoned by denying you resources. They indicated that they work in security and we hire men out of prison or who had criminal histories. But now that sorry, my computer's starting to act up too. But now that we have, sorry, my computer, I apologize. My computer went out and someone said prison industrial complex. They're coming in. It is not new information. They move as fast as you start to read. Men have no real chance if they have been convicted. They are essentially left with no way out of their circumstances. And there are several other good ones. It is not new information. It is sad. It makes me angry. The audacity of this corporation we call a country, the labels, the exile, the stigma is outrageous. And so there are a few more.
Well, I think all of those are just very powerful and emotional. There's an emotional connection when we just, and even though we know this, many of us know this, to hear it and for it to be refreshed, and then for us to synthesize it with what's going on now is just mind-boggling. And so, I want to thank you for putting those in the chat. And again, all of this will be available for you when you receive the PowerPoints. Any more that really stick out, Dr. Tyus?
Yes. This also affects African-American women because we have to continue to step up and be the mother and the father in household. And so I think that's really speaks to a lot about the generational issues in our families too, Dr. Bryant.
Absolutely, absolutely. And so, yeah, every time I watch that video, I just, it just sends shivers through me. And so here's the other thing, and Michelle really brought this home, but just to know that there is a national effort in many states to dismantle all of that knowledge, to dismantle that information. And ultimately, the attack on critical race theory, which the overarching goal here is to erase the memory of what we as African Americans and others as well have gone through to achieve freedom, to achieve progress, to achieve voting rights. All of these things are being threatened nationwide in terms of having our entire history erased. And so again, why critical race theory is so important. And this is something actually was really brought up around the 1970s. I became more organized in, later on, particularly after the civil rights movement. But contextually, critical race theory really examines, explores, and promotes knowledge about our social, cultural, and legal issues as it relates to race and racism. And yeah, when we talk about critical race theory, we see that race really does sort of cross-section almost all of our systems within this country. Again, racism is systematic or systemic and institutional. So as we begin to fill in the gaps, as we begin to dismantle these systems, we have to understand that it can't be just dismantled from an individual perspective. It really does have to be dismantled from a systems perspective. And one of the concepts that's very salient in terms of critical race theory, as well as in terms of us as providers, us as counselors, social workers, is the notion of intersectionality as a key concept. And we'll talk a little bit about that as we move forward. But again, we have to be aware and we have to continue to fight to uphold our history. Our history is powerful, but our history also helps inform other cultures worldwide. And so we cannot afford to have our history erased as some are proposing to do. So let's look at even going a little bit deeper. And that is looking at health disparities among same gender loving men. And the term same gender loving can be interchanged with gay men. Same gender loving is a term that was coined by one of our researchers, Cleo Manago, back in the 90s to sort of really add more affirming definition in terms of African Americans and sexual orientation. So oftentimes we're referred to as Black men who have sex with men. Those kinds, and they have a place in scientific literature in identifying behaviors. But Cleo really wanted to add a definition which was more associated with the relationships within the Black gay community. And that is those individuals that love the same gender and also connects it with relationships, connects it with love, and connects it with how our community, as a community, has come together collectively in terms of those relationships. And so when we talk about salient issues among same-gender loving men, we cannot divorce it from racism as well on top of what we experience as homophobia. And the overarching thing here is when we talk about homophobia, it's not just from the general community, but also homophobia within our own communities, within our own institutions, for example, the church. And so when we look at these intersectionalities, we've got to include all of these when we're talking about identity. And of course, other issues that impact same-gender loving community, substance use disorder, suicide, violence, and of course, as we mentioned earlier, HIV/AIDS. So let's just look at a snapshot. And this really brings home HIV/AIDS in terms of new diagnosis or incidence in the same-gender loving community. You can see here very clear that Black African-American male-to-male sexual contact is at the epicenter of the HIV/AIDS epidemic compared to secondly, Latino, but compared to white male-to-male sexual contact, there's a great disparity there. And so let's look at changing trajectories a little bit and focus the rest of this presentation on solutions. And again, I'd like to co-create solutions with you and not just solutions that we professionals, the science, the literature have come up with, but looking at how we as organizations working with men, African-American men, can better address their needs. And so one area that must be addressed is language. and making sure that we are not engaging in language that is stigmatizing language. And so we'll go over that a little bit in terms of what is affirming language. Also, the issue of intersectionality, really looking at individuals, not just through race or racial lens, but looking at all of the other identities and factors that impact them when they come to see you. Again, we cannot divorce this from social justice or diversity, equity, inclusion, and really allowing organizations to really look at how well they're doing in terms of diversity, equity, inclusion, and what ways they can be more proactive with making sure that no community is left behind in terms of including them in services that promote positive outcome. And also community outreach, as well as the issue of cultural humility. And so one of the questions, and we weren't able to do a poll here, but one of the questions that perhaps we can do this in the chat or have some ideas in the chat, when we talk about cultural competence, I'd like to know if anyone thinks that they are culturally competent. And you can just put in the chat, yes or no. Are you culturally competent in the work that you do? And while we are waiting for that, I'm just going to give you a few minutes for you to think about that. But the question is, are you culturally competent? Give you one more round. Are you culturally competent? So what do we have?
Oh, we have a lot. Let's see. No way, yes, I strive. What did it say? I strive to be, but can't be for. I strive to be, but I can't be for everyone. No, somewhat. Can never be completely culturally competent. Yes, I am. Culture continues to change. There is no final end. I am not, but am trying to understand. No, because competent implies an end and all knowing, not fully, striving for culturally humility. I try to be, but not always.
Yeah, I'm gonna stop there because therein is the answer. When we talk about cultural competence, as several of you alluded to, I don't think we ever become totally competent, because if we think that we're totally competent, then there's no room for growth. There's no room for development. But on the other hand, when we talk about cultural humility, and we'll talk a little bit more about that in a subsequent slide, it really offers us an opportunity for growth, an opportunity for development in an ongoing way. And so rather than just a one-time DEI module that we do, or once every other year, it's really promotes an ongoing opportunity for us to learn about different cultures, for us to learn about different populations. And so one of the solutions that we'll talk about is first, when we look about environmental, and so you went back to the Tuskegee experiment, and so it is such a refreshing time now in terms of racial equity, because an executive order was put out by the Biden administration. So this says what the government is behind, and the commitment of the government in terms of advancing racial equity. And I'm going to read this verbatim because I think this is very powerful, because the might, the resources of the federal government are behind this. And that is through the federal government. And this is Executive Order 13985. Through the federal government, directs agencies to pursue a comprehensive approach to advancing equity for all. Advancing equity for all, including people of color and others who have been historically underserved marginalized, and adversely affected by persistent poverty and inequality. And so just reflecting on that for a moment, that's a powerful statement. That's a powerful commitment. But this is what our government says organizations ought to be doing. This is what our government says that from governmental agencies to local agencies, anyone that's operating and working with populations that are different should be doing this. And I think that as we move forward, we can, just frame the rest of this presentation through the federal government mandate. So we talked about intersectionality. And so what do we mean by that? That intersectionality is a term that was coined by Kimberly Crenshaw. And it really says when we present ourselves for service, that it's more, again, than just our color. It says that all inequalities are connected and cumulative. Biases may be overlapping or unique depending on identity. And again, she says very clearly that race intersects and impacts every system. And so just briefly, we'll talk about just a few elements of this intersectionality. And so in addition to physically how we present ourselves, we have to take into consideration, for example, ability, whether there's some disability associated with that individual, immigration status, age, religion, language, ethnicity, sexuality, gender. All of these things are part of what individuals bring when they come for services. And so when we talk about cultural humility, we are challenged with learning about these different kinds of intersectionalities so that we can help these persons from a person-centered perspective maximally, so again, that outcomes are successful. And so back to stigma, because one of the things that was talked about in the video was how pervasive stigma really is. And so when we are talking about stigma and substance use disorder, stigma really can reduce, or feeling stigmatized can reduce willingness of individuals to seek treatment for substance use disorder and HIV. And it really does go back to what we talked about, and that is a mistrust of the medical establishment. Also, stigmatizing view, we talked about this already, of people with substance use disorder as deserving of the situation that they find themselves in, as opposed to having a more empathetic and affirming approach. And lastly, language, how important language is now. And the good news is we are constantly evaluating language and how we refer to people and referring to them from a more respectful, a more affirming perspective. And so we'll talk a little bit about that in the next couple of slides. So this last video is also a very important video because it really does bring home from Jay-Z and Molly Cranapple, the criminal justice system and how it really impacts our daily lives, particularly as Black men. And so again, this is your chance to use the chat and really, and again, this is just one of the most powerful videos that I've seen that really address this so-called war on drugs, which was more of a war against African Americans. But let's see what Jay-Z has to say.
1986, when I was coming of age, Ronald Reagan doubled down on the war on drugs that had been started by Richard Nixon in 1971. Drugs were bad, fried your brain, and drug dealers were monsters. The sole reason neighborhoods and major cities were failing. No one wanted to talk about Reaganomics and the ending of social safety nets, the defunding of schools and the loss of jobs in cities across America. Young men like me who hustled became the sole villain, and drug addicts lacked moral fortitude. In the 1990s, incarceration rates in the U.S. blew up. Today, we imprison more people than any other country in the world. China, Russia, Iran, Cuba. All countries we consider autocratic and repressive. Yeah, more than them. Judges' hands were tied by tough on crime laws, and they were forced to hand out mandatory life sentences for simple possession and low-level drug sales. My home state of New York started this with Rockefeller laws. Then the feds made distinctions between people who sold powder cocaine and crack cocaine, even though they were the same drug. Only difference is how you take it. And even though white people used and sold crack more than black people, somehow it was black people who went to prison. The media ignored actual data to this day. Crack is still talked about as a black problem. The NYPD raided our Brooklyn neighborhoods while Manhattan bankers openly used coke with impunity. The war on drugs exploded the U.S. prison population disproportionately, locking away Black and Latinos. Our prison population grew more than 900%. When the war on drugs began in 1971, our prison population was 200,000. Today it is over 2 million. Long after the crack era ended, we continued our war on drugs. There were more than 1.5 million drug arrests in 2014. More than 80% were for possession only. Almost half were for marijuana. People are finally talking about treating addiction to harder drugs as a health crisis, but there's no compassionate language about drug dealers. Unless, of course, we're talking about places like Colorado, whose state economy got a huge boost by the above-ground marijuana industry. A few states south in Louisiana is still handing out mandatory sentences for people who sell weed. Despite a booming and celebrated 50 billion legal marijuana industry, most states still disproportionately hand out mandatory sentences to Black and Latinos with drug cases. If you're entrepreneurial and live in one of the many states that are passing legalized laws, you may still face barriers participating in the above-ground economy. Venture capitalists migrate to these states to open multi-billion-dollar operations, but felons can't open a dispensary. Lots of times those felonies were drug charges, caught by poor people who sold drugs for a living, but are now prohibited from participating in one of the fastest growing economies. Got it? In states like New York, where holding marijuana is no longer grounds for arrest, police issue possession citations in Black and Latino neighborhoods at a far higher rate than other neighborhoods. Kids in Crown Heights are constantly stopped and ticketed for trees. Kids at dorms in Columbia, where rates of marijuana use are equal to or worse than those in the hood, are never targeted or ticketed. Rates of drug use are as high as they were when Nixon declared the so-called war in 1971. 45 years later, it's time to rethink our policies and laws. The war on drugs is an epic fail.
Okay, that was a lot. That was a lot. I think Jay-Z did a wonderful job of really conceptualizing what we've been talking about this entire presentation. And so, want to hear from you. Want to hear from you in the chat. Anything in the chat yet?
Says folks with felonies are not eligible to grow marijuana. We are acutely aware that Blackness compounds negatively with any trait. With Blackness comes an extended vulnerability to any isms of the world and the violence that comes along with it. And that says Lene Vani 2022. Can you post the link to the, let's see.
The link to the video?
Yes.
I did already.
Yeah, she did already.
Okay.
The documentary 13th looks at the expansion of the prison industrial complex as a response to the abolishment of slavery. And there's a YouTube link that you can watch.
I captured it, Miss Tam.
Okay.
Thanks you for that. Thank you for sharing that. And again, I mean, I think these, your input is valuable and certainly speaks to the power of that video, but also the truth that's inherent in African Americans and how we are treated through the criminal justice system. So when we get back to racial equity and what does that look like? And what is our challenge? What is it that we can do actively? Like when we leave this presentation, we go back to our jobs, go back to our homes, go back to our communities. What is it that we can actively do? What are the things that we can change? Because ultimately, to make any kind of inroads, we have got to make changes, and we have got to change. So again, racial equity means closing the gaps and asking ourselves, what is it that we can do to help close these gaps? And one of the things I think is of paramount importance, and that is in any solutions, we have to be co-creators. We have to have the voices of African Americans to let scientists, let professionals, providers know what their needs are. And so in the last few slides, let's look at and begin to look at some evidence-based solutions. So according to CDC in 2022, when we talk about substance use disorder, as well as HIV/AIDS, we've got to increase access and reduce barriers to treatment. And again, if you go back to the statistic that I mentioned earlier, even in neighborhoods where there are perhaps more treatment centers than other neighborhoods, that does not necessarily mean that there's an increase in access. Because when you look at things like insurance, when you look at, again, going back to the issue of trust, when you look at, are there affirming places, for example, same gender loving men, so that they can receive the same kinds of treatment, that others, but based on perhaps some of their special needs. Also, what is driving the substance use disorder epidemic is fentanyl, as well as polysubstance use. So oftentimes, I had the privilege of directing the state of Georgia's response to the opioid epidemic through the Georgia Department of Public Health. And one of the things in that research that we did in developing a statewide plan for the epidemic, most individuals during autopsy or those that had an overdose usually had more than one substances in their system. And so we really do have to look at this, again, from a polysubstance use perspective. And also support harm reduction by expanding education, and particularly around making naloxone, which is a life-saving reversal drug for those that have an opioid overdose. But it has to be accessible. And it has to be accessible at the point where oftentimes these overdoses occur. And so I think we're still challenged with making sure that, they come from behind the counters of pharmacies and really put in places that makes it very easily accessible for families, so that if they do witness an overdose, they're able to utilize naloxone. Because again, naloxone is life-saving. And one of the things that I've had the privilege to do for the last 45 years is be a respiratory therapist. And I'm still a practicing respiratory therapist. And we're the ones who literally get these overdoses in the emergency department. And I tell you how miraculous naloxone is in absolutely saving the lives of many of these people. But also, when individuals are not restored, their breathing, and have to go on mechanical ventilators, I really think it presents a great opportunity for individuals that are already in recovery, individuals who have experienced this already, can also be in place to help these individuals in terms of providing knowledge and information where they may be able to get resources, and also where they may be able to get help as well. And again, when we talk about expanding education, we really also have to talk about embracing harm reduction as well. And so talking about cultural humility, that word arises again. So just in terms of the definition, and I think the National Institute of Health really defines it fairly accurately. And so they define cultural humility as a lifelong process of self-reflection and self-critique, whereby the individual not only learns about another's culture, But one starts with an examination of his or her own beliefs and cultural identities. That's powerful because we all bring to the table some kind of personal bias. And we'll talk a little bit about that because we have a beautiful tool that we can use called the addressing framework. And this was done by Pamela Hayes. But it really is an opportunity for us as an organization to use this as a tool to begin to have our staff, employees, begin to identify their own biases. So Pamela Hayes looks at 10 different cultural influences. And this is not all inclusive by any means, but she looks at age as a factor within this framework. She looks at developmental disabilities as well as acquired disabilities. She looks at religion and spirituality, ethnic and racial identity, socioeconomic status, sexual orientation, indigenous heritage, national origin, as well as gender. And so what this model helps to do is for us to identify which populations we may have difficulty working with, which populations that perhaps we absolutely cannot work with. So for example, myself, I would have a very difficult time working, for example, with middle school children, or even to a lesser extent, high school children. So I would not put myself in a position where I'm literally either teaching in that space or having to interact with that population in an ongoing, as something that I do all the time. And so that's one of my biases that I've had to work through, and I've gotten a little bit better with it. But overall, I don't really work with that population. But there are others around gender, of course, and other kinds of things where we can begin to just get honest about our own biases and address those, and assess where there are situations where we have privilege. So, for example, and until I really looked at this model, I didn't really think about my privilege in terms of male and being able to go out after hours anytime that I want to without having to worry about, to as much extent as women do, about safety, those kinds of things. And so we really look at where we have privilege in this model, as well as looking at those situations where we don't have privilege. And so the link is in this presentation at the bottom in terms of where you can actually find copies of this model. And now what I think is just very, very important, the Addiction Technology Transfer Center really does put out a document called Language Matters. And so when we start to talk about language and how important language is in terms of destigmatizing our interactions with vulnerable populations, we can begin to change how we interact with our clients. So for example, when we're looking at substance use, for example, we look at what language that has been considered stigmatizing and what is preferred language. Now, I'm not going to go over every single one of these, but I believe that I did put the link to this in the PowerPoint. But for example, instead of using the word addict, we try and move more towards person-centered language. And so refer to them in a more affirming language as a person with a substance use disorder, as opposed to referring to them as addicts. Another one, for example, when referring to someone stigmatized language as having a dirty screen, we really want to change that language to saying that a person testing positive for substance use. In another one, towards the bottom, instead of using the term relapse, which does have some negative connotations to it, we affirm and we say that this person resumed or experienced a recurrence of substance use. And so, as you can see, this is something that we can print out and we can put it next to our desk and just use this in our daily interactions so that we are using a language which is more affirming, language which is more respected in terms of substance use disorder. And also, when we're looking at language in terms of the LGBTQ plus community, and of course, we know in terms of stigma that this community is one of the most stigmatized community in society. And so, for example, instead of using the term homosexual, we use the term gay people. Instead of sexual preference, which is really derogatory and just a non-factual kind of a term, we use the term sexual orientation. And so also, again, instead of, when we go down towards the bottom, instead of using the term, negative terms like tranny, we use terms like transgender. And this is a mistake. It should not have an ED on the end of it. It should be transgender. And so I want to make that very clear. This is an oversight, and I apologize for that. But transgender, or just trans people or trans person. And so again, these are opportunities for us to really change the way that we do work, change the way that we interact with these populations. And the other thing, when we're looking at, for example, organizations and leaders, and how leaders can begin to invest in diversity, equity, and inclusion, and making organizations more inclusive for the African-American populations, but also for other populations as well. And so one of the things that's important is recruitment and hiring. And the recruitment should reflect the population that is being served, not just at the staff level, but also at the administration level, also at those organizations that have boards of directors. Also, the board of directors should also reflect the population that's being served, because oftentimes, and you know, as far as some of the research that I've done and others have done well, oftentimes persons want to see people who look like them when they are interacting with the healthcare establishment. And also reflect how your staff, again, reflects the population, but also keeping data on recruitment and hiring practices. And that's not very hard to do, particularly when we're talking about healthcare facilities. We now have mechanisms that's very easy to track the makeup of your department. Again, does your department, not just at the staff level, but also at the administration level, does it really reflect the population that's being served? And also, yeah?
Dr. Bryant, we're 10 minutes to the hour as you requested.
Okay. Well, I'm almost finished. And so the other thing is really looking at equity versus equality, and really moving our services more towards equity, such that outcomes for our population is what's being driven, so that our populations, our clients, are receiving exactly what it is that they need in order to be successful. And so this is just a powerful quote by our own Nelson Mandela. And he says that we can change the world and make it a better place. It lies in your hands to make a difference. And so I'm hoping that you've heard something that will help change the way that you do things, whether it's language and changing the way that we refer and interact with persons that are different, whether it's adopting a commitment to cultural humility. And again, there are so many educational opportunities that are available, such as this one, that are free, that we can continue to educate ourselves on different cultures, educate ourselves on different trends in terms of substance use, as well as HIV and AIDS. And, many of them are virtual. Of course, there are many free that are also face-to-face, but it really does give us an opportunity to continue our own trajectory, to continue our own education, such that when we are interacting with our clients, that we are utilizing our abilities, our skills, to be able to impact them positively, so that, again, they are able to achieve positive outcomes. And lastly, in our 5 minutes, and we'll have a little time for questions and answer, this is my information. And again, it'll be in a PowerPoint. I am part-time faculty at Kennesaw State University, and there's my email address. Feel free to email me. And also, I am CEO and founder of Passion and Purpose Consulting, and we offer many of these kinds of presentations, not just around substance use disorder, not just around culture and diversity, but also other things such as HIV and AIDS. Particularly, I'm very passionate about HIV and AIDS among an aging population. And also, we don't talk a lot about substance use disorder among an aging population. And so those are areas that we have opportunities to educate ourselves on, as well as growth and development. And so anytime, again, you want to get in touch with me, please feel free to do that.